primary ankle-closure is a common scenario in our country. And for some cases of PAC, that is primary ankle-closure, we have to face lots of problems. So we need to treat them aggressively to save the patient. With this introduction, I will present my case. This is a 47-year-old female presented to me with history of acute ankle closure, left eye for 1.5 months, and she was on 3 anti-glaucoma medications. In right eye, LPI was done. Visual acuity in right eye 60, and in left eye 60. Intraocular pressure was 12 in right eye and 14 millimeter mercury in left eye. Both the lens and optic nerve was normal. And this is the case. You can see pupil is widely dilated due to complete paralysis of the pupil. Angle closed with 360 PAS. Anterochamber is very shallow with high lens force. So my diagnosis was right eye PACS and left eye PAC medically confirmed after acute attack. So the traditional management of PAC was anti-glaucoma medications plus PAC. In this case, it is not possible. And then we look for ALPI. There is a question about its effectiveness, and there is another option that is chronically fluorescence. So what was my challenges? Anterochamber was extremely shallow, people dilated, people in muscle paralyzed, and 360 PAS. So my aim was to reduce the main volume of anterochamber. So I planned for we need to do it by phaco emulsification, that is clear lens extraction. Phaco can reduce the bulk of anterochamber, and is it enough? What about the 360 PAS? There is an option, we have trabeculectomy. Here, trabeculectomy is not suitable. The rate of complications and risk of revision is high. So I had to look for another alternative, that is goniosynovial. Phaco goniosynovial eliminates the pupillary block, deepen anterochamber, and deepen adherent angle. Then we have another problem, that is large pupil. So these are the pupillary abnormalities with PAC, and all these eyes are on pilocarpine lifelong. To avoid this, we have to look for another alternative, that is pupilloplasty. It facilitates the reconstruction of the pupillary shape and size and prevents iris from falling back into the angle. So my plan was clear lens extraction followed by goniosynovial, followed by pupilloplasty. The preparation of the patient for surgery is an initial and crucial step. I started preoperative steroids, both topical and systemic, 2 days back, and I also injected intravenous menthol just before surgery for smooth perioperative procedure. Always, it is difficult to do phaco in angle closure cases. All the possible complications of phaco surgery could happen in this case. So, keeping all these things in mind, surgery was started under peripheral anesthesia. Staining was done to enhance the visualization. The length of the tunnel is clearly longer than standard injected viscoelastic substance. Then did a standard central cervicular capsulodissection. Meticulous hydrodissection and delineation was done. And I changed my phaco settings from lower IOP to higher IOP. There is a challenge to do a phaco in a large, big and soft lens. So I tried to make a small trench and break the nucleus into 2 halves, then emulsify it subsequently, and the nucleus and cortical matters were taken care of and ensured intact IOL implantation. Then injected pilocarpine to constrict the pupil, but you can see there is no response. Then injected viscoelastic to deepen the anterior chamber, and the operating microscope was then tilted approximately 45 degree, and also eye was tilted. Then sonograph lens is placed over the cornea, and PACS was gently broken under direct visualization by pulling the peripheral iris attached with the peripheral cornea. Always there is a chance of little hemorrhage. It will absorb over time. It will create no problem at all. The end point of the procedure was visibility of the scleral spur, and the maneuver was done repeatedly to cover almost all the angle. Now the pupillary margin was grasped with iris forceps and pulled towards the center. This pupillary stress maneuver was performed around the interpupillary margin. Anterior chamber was inflated with viscoelastic substances, and a 10-0 Prolin suture with a straight needle was introduced through the paracentesis to the proximal iris tissue while the forceps grabs it, and the needle passed through the distal part of the iris tissue. And after 2-3 repressions, the needle was docked in the barrel of 26 gauge needle, which was withdrawn from the eye. And a Lister hook was introduced to take out the loop of the suture from the eye. And then the suture end was passed through loop 4 times. And both the ends are pulled out from either side of the eye, which approximate the lobes inside. Then the suture end was cut with micro scissors, and the same procedure was repeated at the opposite side. Anterior was being done, and this is the appearance at the end of the surgery. And after 2 months, this is the appearance. You can see the eye is very much white, and the vestibular visual acuity was 6/6. Intraocular pressure was 40 millimeter of mercury without any anti-glaucoma medications. Angle open with few small synechias. And there are lots of study which gives us evidence for the role of clear lens extraction in the management of PAC. This is a well-known RCT, and this is called Eagle stand. The Eagle study was designed to see the effectiveness of clear lens extraction in the management of PACG in comparison to laser peripheral iridotomy. After 3 months of follow-up, they concluded that clear lens extraction was superior than standard care in terms of patient health status, IOP control, future needs of glaucoma medications or surgery, and also cost effectiveness. And it should be considered the initial treatment for management of PAC and PACG. And the goniocellular paralysis will help us in these cases by mechanically breaking the peripheral enterosynechiae, reopening of the anterochamber angle with the assumption that trabecular meshwork and drainage system will resume functioning after reopening. And the pupilloplasty elevates the appositional closure, and it prevents the iris from retracting back in the angle. So my take-home message is that PAC GSL is effective and safe in the management of PAC. It eliminates pupillary block, defends shallow anterochamber, and reopen the closed angle by breaking PACs. And pupilloplasty is an effective modality to maintain the reopen anterochamber angle. So thank you very much for your kind attention.